Hello everyone, a warm welcome to you from SGT University. Today we are here to discuss about the dislocation of shoulder, and for that we have an expert, Dr. N C Arora, Professor in the Department of Orthopedics, Faculty of Medicine and Health Sciences, SGT University. Welcome sir. We all know that dislocation is an injury in which joint forced out from its normal position. This commonly happens when a person falls or in case of an accident or sometimes when people used to participate in the sports activity. This is an emergency medical condition which requires prompt treatment. Common areas which are involved in the dislocation are shoulder, elbow, hip, knee and even fingers. But the most common one is the dislocation of the shoulder joint. Sir, I'll appreciate if you tell to our audience what actually is this shoulder joint consist of and what is this dislocation of shoulder joint. And many of times I heard in news that following athlete falls and leads to the dislocation of the shoulder, and many of times even actors who are working for a movie have this dislocation of the shoulder. So I'll appreciate if you tell to our audience what actually is this all about.
Thank you. Actually, shoulder joint is a complex joint, and this complex joint, why I say it is a complex joint? Basically, there are three bones involved: the collarbone, which is called the clavicle, the shoulder blade, technically called as scapula, and the humerus, which means a funny bone. So basically, shoulder joint is an articulation between the glenoid, this is the glenoid, and the head of the humerus. But having said that, it is actually when the movement at this joint takes place, the movement also takes place at the joint between the shoulder blade and the clavicle, that is the acromioclavicular joint, the sternum and the clavicle, the sternoclavicular joint. So that is why I say that it is a complex joint. Not only that, the scapula itself, the shoulder blade itself moves with the movements of the shoulder. Shoulder joint is a very versatile joint. It has, as we are all aware, that it moves in all directions, unlike other joints, like elbow joint moves only in this direction. The hip joint also moves in limited directions, but this is the shoulder joint which moves in every direction. In every direction, it has got a movement called, when it moves forward, it is called flexion. When it moves backwards, it is called extension. When it moves upwards, it is called abduction. And then when it moves inward, it is rotation. And when you scratch your back, even then it rotates. Now, what happens is that the movement does not only take place between the head of the humerus and the glenoid. When this moves, the scapula also moves, though, and it moves in the ratio of 2:1. The glenoid and the head of the humerus moves twice as much the scapula. So the movement alone is not there. So that is why every movement is a complex movement. It involves the acromioclavicular joint, the sternoclavicular joint, the scapulothoracic joint and the glenohumeral joint primarily. So now you see that how much stress is there on the shoulder joint. Now you see the weightlifters, they lift up to 100 kg, more than that. Now you see cricketers, spin bowling, fast bowling, so all these things, rugby players, volleyball players, and in our day-to-day activities, we have to push something. Every movement takes place at the shoulder. So you can well imagine that shoulder joint movement, even while you are walking, your shoulder joint is movement because of your hand movements. While you are running, automatically your shoulder joint moves. So the shoulder joint cannot be stand still, it has to move. even while you are walking or running. Now, shoulder joint is basically a very unstable joint. You can see that the glenoid is very shallow and the head is so big. So, how you can well imagine that is very unstable joint. Now, the stability to the joint is provided by the ligaments and the muscles. So, now there are three important ligaments which we call as superior glenohumeral ligament, the middle glenohumeral ligament and the inferior glenohumeral ligaments. There are three ligaments and all these three ligaments are very important, but the most important is the inferior glenohumeral ligament. Now they have a hammock like effect, all these ligaments. When the head moves anteriorly, the posteriorly it fans out, the ligaments fan out. When it moves posteriorly, the ligaments fans out anteriorly. So, it is just like a hammock. Now, actually when the contact between the head of the humerus and glenoid is just about 25%, but it is stable, it is stable. Now, there is a structure called cartilage structure which is known as the labrum, so which makes it little deeper. So, the contact with the labrum and the glenoid from 25% it becomes about 75%. Now having talked about the ligaments, to talk about the muscles, we have rotator muscles. The rotator muscles being subscapularis, supraspinatus, infraspinatus and the teres minor. These four muscles also provide stability. Now that is not enough. Now there are some muscles of the scapula which also provide stability to the shoulder, like trapezius, the latissimus dorsi, the serratus anterior. These are the muscles which also provide stability. Now commonly we see that the muscle which we normally see is the deltoid. Everybody knows that this is the deltoid muscle, but deltoid muscle provides no stability to the shoulder joint. Rather, when we do the abduction movement of the joint, deltoid tries to pull the head superiorly. So, it rather provides some kind of instability to the joint. Now, what I said was that basically the joint is inherently unstable, and to make it stable we have ligaments and the muscle. Now, to tell you further that this is not a plain simple movement like this. I told you that there is scapular movement and there is some amount of roll back of the head over the glenoid. So, the labrum also limits the roll back so that it does not dislocate either anteriorly or posteriorly.
So, what all complaints patient comes with when you see them in your OPD, and how will you diagnose such kinds of dislocation, and after the diagnosis how one will manage this case?
Very good question. Now normally what happens is that there is a usually fall on the outstretched hand. The patient falls something like this and the joint dislocates. Sometimes it happens in accidents. Commonly it is seen in athletes who are doing this vigorous athletic activities. So, out of all the dislocation of the joints, statistically we have seen that 50% of the dislocations are in the shoulder joint. So, it is very common, rather the commonest of the dislocations. Now, how does the patient present, you ask me? Now, the patient, it is an emergency. The shoulder patient has acute severe pain after the dislocation. He is unable to abduct his arm. And normally the patient becomes aware, yes, I think something has gone wrong or something is amiss. I think I may have a dislocation. Now, these patients normally present to the OPD Now, supposing my right shoulder is dislocated, they normally present with holding their supporting the elbow with the left hand because it is painful. So, there is a history that the patient had a fall, patient has come supporting his elbow, does not allow movements of the shoulder joint, and what happens is when you try to see the shoulder joint, you can actually sometimes feel the head just in front of glenoid or the coracoid process, or sometimes below the clavicle even. So, when you try to move this, you can actually feel the movement of the head in this place rather than here. So, either below the coracoid or below the clavicle or in front of the glenoid. So, these are you try to move the head and it moves there, and instead of you can feel, yes, it has gone out of the glenoid, the capsule, this thing. Now, when you examine clinically further, you find that the shoulder there is some hollowness. It is known as the sulcus sign. It is known as the sulcus sign that the shoulder is hollow. So, that is we come to know that this thing. Then there is something known as the shoulder is round, and when we try to put a scale right there. So, normally when you try to put a scale around your shoulder, you cannot straight put a scale on this. So, and when this happens, now this has gone inside and they come in a single straight line. So, this is known as Hamilton ruler test. When it can come in a straight line, this is known as Hamilton ruler test. That is one of the tests of the dislocation. So, saliently there is hollow, the sulcus test is positive, you may find the head somewhere in one of the three positions I mentioned, and finally you may find the Hamilton rulers test, and there is another test. You ask the patient to touch the opposite shoulder. Patient is unable to touch the opposite shoulder. This is known as the Dugas test. So, having done these tests, clinically we can be reasonably sure that this patient has a dislocation of the shoulder. Now, to confirm our diagnosis in these patients, we do an X-ray. Anterior posterior view is enough. Sometimes we need a axillary view which shows us the type of the dislocation as well. We can make it from the AP view also. It is just to confirm the diagnosis. At this stage, in this emergency situation, it is not necessary to have a CT scan or a MRI scan. So, we have various types of dislocation. We have an anterior dislocation when the head moves anteriorly. We have posterior dislocation rarely when it moves posteriorly. In 97% of cases we have anterior dislocation, and very rarely we have posterior dislocation, and it is seen in epileptics when they have an epileptic attack or after electric shock. Clinically, in day-to-day practice, in a person who is not epileptic or he hasn't had electric shock, posterior dislocation is very, very rare. So, normally when we say my shoulder got dislocated, it obviously means that it is anterior dislocation, because in 97% of cases it is anterior dislocation. Now, having done the X-ray and having confirmed the diagnosis, now how do we manage? So, there are various techniques described. So, the commonly one used is the Cocker's technique, in which we give traction on the elbow, then it goes by the mnemonic TEAM, TEAM, TEAM. So, you give traction, then you externally rotate, then you adduct the limb, and then you internally rotate. So, the head goes inside with a clunk. It goes into the glenoid fossa immediately. So, this is rarely unsuccessful. So, then we have if this method fails, sometimes very rarely, then we have a method called Hippocrates method. Old time Hippocrates described it. Then what happens is, even the wrestlers in our country try to do that. They put a leg in the shoulder joint, in the axilla, and then try to pull it. It sometimes, or in cases of failure, it is successful. Lastly, there is another method. When all the other methods fail, then we put the patient prone on the bed with the tummy on the bed. So, and then we try to pull along with the gravity. So, it automatically comes into this, known as Stimson's method, very rarely required, practically just to be mentioned. So, the most common is Cocker's, and then comes the Hippocrates method. Now, for this, doing this procedure, we have to either sedate the patient or put the patient under general anesthesia for a short while. They give some muscle relaxants and the reduction becomes much easier. Now, after having done the reduction, we put the patient, advise the patient to use a cuff and collar sling or a broad arm sling pouch for about 3 to 4 weeks, so that it becomes stable.
Sir, just now you have mentioned that many techniques are used to correct this dislocation. Do any of the patients require surgery to correct this dislocation of the shoulder? And what happens if patient not able to come on time after any injury or fall or accident? And if someone is living alone and who neglects the case because of non-availability of any spouse or their children, then how we will manage in such situations? And one thing more I want to ask, that is there any recurrence of this dislocation of the shoulder?
Good question. First, I will answer your second part of the question first, especially the old people.
Yes, sir.
Living single, unattended. It's a very common problem nowadays. They are liable to fall very often at home, nobody to attend. So, it happens that they may present with neglected dislocation. So, in these cases, we still attempt close reduction, and usually for first few days it is successful. But supposing they present after 1 month, month and a half, then we still try close reduction, but we know it that it will not come back. We may have to resort to open reduction, the surgical procedure. So, we go prepared for the surgical reduction. So, that is one part of this thing. Sometimes it so happens that these patients do not follow the norm of putting the cuff and collar sling and this thing. And as I mentioned previously, that when we have movements in various directions, so we have various types of instability also, because so many types of movements. So, there can be the instability can be unidirectional in one direction, it can be in 2 directions bidirectional, or it can be in multiple directions, known as multi-directional instability. So, we have to assess clinically unidirectional, bidirectional or multi-dimensional instabilities as well. I also wanted to mention that in acute dislocations, these patients may also have nerve injury. So, the axillary nerve gets damaged, and there is an aesthetic patch over the region of the deltoid, and the army people like where they put their regimental badge. So, that is the area which becomes anesthetized or numb. So, that is also known as regimental badge sign. So, axillary nerve involvement, though not very common, but still can occur, and one must also look for it. So, I told you that the close reduction is the gold standard, but should it fail in neglected dislocation, rarely we may have to do open reduction. But I should also not forget to tell you that the elderly people do not have much requirement of the shoulder joint movements because of the restricted stay at home. Most of the time they are homebound, and very little movement. So, they can also be given some kind of physiotherapy at home to regain some movements, functional movements of the shoulder. All right. So, that is it. Now, what happens is that there is a paradox here, that if the initial injury has been very severe, and depending on the nature of injury as well, it is seen if the injury is severe, the dislocation incidence is low. That is a paradox. But if the initial injury is less severe and also the nature of injury clubbed with that, there may be frequent recurrent dislocation. So, this is a paradox, but it is true. Statistically, it is true. Now, the biggest problem of the dislocation of the shoulder is that whether you put them in the arm sling pouch or you don't put. Recurrence depends on the initial injury. If it has damaged the labrum, which is the commonest injury, so it is known as Bankhart's lesion. So, Bankhart's lesion is when the labrum is avulsed from the glenoid. So, that is the Bankhart's lesion. Along with it, there may be a bony fragment going with it. It is known as bony Bankhart's lesion. Now, at the time of injury, if suddenly the head gets stuck against the rim of the glenoid, it creates a small cavity in the head of the humerus, which is responsible for recurrent dislocation when you abduct the arm. It is known as Hill-Sachs lesion. It is a defect in the posterolateral part of the head. So, these are three important lesions: the capsular laxity, which I said unidirectional, bidirectional, multidirectional, and some people have ligamentous laxity from birth, like Ehlers-Danlos syndrome. So, all the ligaments are very lax. One has to be very careful in decision making. If you have to see the other shoulder joint, you have to see the other joints. If they are hyperlax and we tend to take them for the surgery, it is going to be disastrous, because you will not able to tackle so much of capsular laxity, and all the capsules are lax in all the joints of the body. So, that is also very, very important. So, then we have the biggest problem of acute shoulder dislocation, or the complication is the recurrent dislocation. And I must tell you that the diagnosis of recurrent dislocation is done by there are many tests again to do this. The first thing is that you try to abduct and externally rotate, and it is known as the apprehension test. Patient feels that the joint is suddenly unstable and tries to resist that movement. Then there is a Latchman test, in which you try to establish the anterior posterior subluxation of the head of the humerus over the glenoid while lying down, and there are tests while sitting down for testing all this. Now, having established clinically that this patient has recurrent dislocation of the shoulder, we call it recurrent when more than 3 episodes of dislocation have taken place. We should also be careful to see that it is not subluxation. Subluxation means little bit of movement going little forward or little backward is subluxation. So, it is not only, it should be frank dislocation, 3 episodes or more episodes, when we label it as recurrent dislocation. Now, that is the time when we need to do a CT scan or the MRI scan. The indications for CT are, one thing is when there is a bony Bankart, because MRI will not show the bony Bankart or may not show as well the bony Bankart lesion. Then we have to see the this is the glenoid. So, now we have to see the version of the glenoid. This is the version, this is the movement of the glenoid. So, if the glenoid is looking backwards, so obviously there are more chances of anterior dislocation. So, we need to see that. Third, we need to see is the Hill-Sachs lesion. So, the surgery will depend on the type of lesion. So, on CT scan we can see the bony lesions, but to see the Bankart lesion, the classical Bankart lesion, which is a soft tissue lesion, we need a MRI scan. Both are complementary to each other. Now, going back further, now the previous years the surgery used for recurrent dislocation used to be an open surgery, and in the last about say 20 years or so roughly, it is all arthroscopic surgery, what we call as pinhole surgery. Now, the open surgeries are virtually out except for a very limited indication. Even some people with advanced arthroscopic techniques, they can do that procedure also, bony procedures arthroscopically also. But now the book describes more than 150 procedures for the surgery of the recurrent dislocation of the shoulder. So, what does it mean that none of them is satisfactory? None of them is 100% satisfactory. It means if you have to repair the Bankart lesion, surgery is different. If you have to manage the Hill sac lesion, it is different. If the labrum is detached, there is a different, you may have to reattach the bony part, and if there is still you find that the glenoid is very shallow, there may be some other procedure required. Now, the commonest in about 85% of cases we have soft tissue lesion, the Bankart's lesion. So, in 85% of the cases the surgery is Bankart's operation. In few cases there is bony Bankart, it means that bone is avulsed, you have to fix the bone again back to this thing to attain the natural glenoid. And if you, I told you initially that the glenoid provides only 25% coverage, the labrum provides another 50%, so that makes it 75% contact. So, you reattach, you mobilize the labrum again arthroscopically from the glenoid neck, move it back, and we use nowadays what is known as suture anchors. These are biodegradable material, and the learning curve for shoulder arthroscopy is very steep. It is not easy. It is not easy that you will seen it once, assisted once, and you will be able to do it once for all. No, the learning curve is very steep. It varies from few weeks, months, and sometime a year even to learn this technique. And then you have multiple procedures. Now we have something known as, if this portion is not giving stability, it is going repeatedly interiorly. You see this coracoid process. We cut this coracoid process and bring it in front of the glenoid. That is known as the Bristow's procedure. Again, there is a procedure in which the coracoid is again cut and is fixed vertically like this, not head on like this, but vertically like this. That is known as Latarjet procedure. And for tackling the Hill sac lesion, we put the infraspinatus muscle in the whatever you call the gap or the defect, and we again put a suture anchor there and fix it there. So, that is another procedure. So, the common procedures followed are, I said in 85% of cases Bankart would suffice. And if there is a large Hill sac lesion, we may have to tackle the large Hill sac lesion. Rarely we may need to do Bristow's procedure or Latarjet procedure. So, these are the management of this procedure. Recurrence is very common in acute shoulder dislocations, irrespective of the fact whether you gave the patient a triangular sling or a broad arm sling pouch or this thing.
After the surgery, do any of the patients require any sort of rehabilitation as well?
Yes, madam. This is most important. Any surgery would be unsuccessful if there is no proper rehabilitation. It is as important as surgery itself. So, typically I will give you tell you briefly about rehabilitation protocol following a Bankhart's procedure, which happens in about 85% of cases. Now, having done the arthroscopic Bankhart's repair, we put the arm in arm sling pouch and we tell the patient to carry out movements of the elbow and the wrist, but shoulder movements are usually restricted for 3 to 4 weeks. Now, then gradually we allow the patient to do little flexion extension, and abduction is usually restricted. And after about a month, another month or so, then gradually we allow, by the time we expect that the operation has succeeded, and gradual abduction in about 3 months time, 2 to 3 months time, and then muscle strengthening program for next couple of months. It takes about 6 months for the patient to have full abduction and full range of movements, and it would possibly take about a year for an athlete of fame to go back to his athletic or activities which he was undertaking initially. It takes about a year, and still there is recurrence after surgical procedure in about 3, 4, 5% cases. So, rehabilitation, muscle strengthening exercises are very, very important. They take much longer than the surgical procedure. 6 months is the time for regaining full movements and about a year for going back to your original activity.
Thank you, sir. So today we have Dr. Arora with us, and sir has explained very well about all the myths related to the dislocation of the shoulder, all the facts regarding this, and the most common type of dislocation is the anterior dislocation of the shoulder joint, and 90% of the times we manage this situation by close reduction only, but still a patient has a fear of recurrent dislocation in their mind as well. And in cases of the recurrent dislocation, we go for the surgical procedures. So again, I would like to thank sir for sharing your valuable time with us. Thank you.